Evaluation of laryngeal function assesses the structure and function of the larynx. CPT code 92520. This presentation, led by Dr. Padin, will guide participants through the comprehensive evaluation process for identifying voice disorders. Remember, CPT code 92520. Evaluation of laryngeal function, CPT code 92520. Clinical assessment of the structure and function of the larynx, typically involving auditory perceptual and/or instrumental techniques, to evaluate voice quality, vocal fold movement, and airway patency. Review the order of speech process. Breathing provides the airflow and power needed for speech. Controlled exhalation supports voice and sound production. Phonation, voice. It occurs when vocal folds vibrate in the larynx as air passes through, creating a voice sound, the buzz of the voice. Articulation, sounds. Shapes the sound into specific speech sounds using the lips, tongue, teeth, palate, and jaw. Resonance modifies the sound as it travels through the oral and nasal cavities, giving voice its quality and tone. Voice parameters are the measurable features used to assess and describe vocal quality, function, and health. The main voice parameters include 1. Pitch, fundamental frequency, perceived as how high or low a voice sounds, related to the rate of vocal fold vibration. 2. Loudness, intensity, the volume of the voice, influenced by subglottal pressure and vocal fold closure. 3. Quality, the character or timbre of the voice, e.g., breathy, hoarse, strained, reflecting the regularity and symmetry of vocal fold vibration. 4. Resonance, the amplification and modification of sound as it passes through the vocal tract, can be oral, nasal, or pharyngeal. All this according to gender, age, and physical constitution. Various voice conditions may exist, some of which result as side effects of other medical conditions. The most common are classified under the ICD-10 system. Common ENT laryngeal ICD-10 codes. Case history. This history helps the speech-language pathologist, SLP, or ENT to correlate subjective symptoms with objective findings, guiding the next steps in assessment, diagnosis, and treatment planning. Demographic information. Name, age, sex, occupation, and voice use demands, e.g., teacher, singer, public speaker. Chief complaint. Patient's primary concern or reason for seeking evaluation, e.g., hoarseness, vocal fatigue, pitch changes. History of present illness. Onset, sudden or gradual. Duration and progression. Triggers or relieving factors. Associated symptoms, e.g., throat pain, cough, swallowing difficulty. Voice use and vocal demands. Daily vocal use, professional and non-professional. Singing or speaking habits. Vocal hygiene practices. Use/misuse of voice, e.g., yelling, excessive talking. Medical history. Respiratory conditions, e.g., asthma, reflux. Neurological disorders. Allergies. Surgeries or intubations. Previous voice disorders or treatment. Psychosocial and emotional factors. Stress levels. Anxiety or depression. Impact of voice disorder on social, emotional, and occupational functioning. 7. Medication and substance use. Medications, especially antihistamines, steroids, inhalers. Tobacco, alcohol, or caffeine use. Reflux symptoms. Heartburn, throat clearing, sensation of lump in throat, globus, chronic cough. Previous voice therapy or ENT evaluations. Prior diagnoses, laryngoscopy results, or therapy outcome. Laryngeal imaging/visualization. 1. Indirect laryngoscopy. A mirror-based examination of the larynx. 2. Flexible fiber optic laryngoscopy, nasopharyngolaryngoscopy. A flexible scope is inserted through the nose. Allows visualization of the larynx during speech, breathing, and swallowing. Often performed without anesthesia, can be recorded. commonly used in clinical ENT and voice evaluations. 3. Rigid laryngoscopy. A rigid endoscope is inserted through the mouth. Provides high-resolution imaging of the vocal folds. Better visualization of vocal fold lesions. Limited to sustained phonation due to discomfort. 4. Stroboscopy. Uses a strobe light in conjunction with rigid or flexible endoscopy. Captures vocal fold vibration in slow motion by syncing with frequency. Assesses mucosal wave, symmetry, glottic closure, and periodicity. Important. Gold standard for functional voice assessment. 5. High-speed video endoscopy. Captures actual real-time vibration of the vocal folds, up to 4,000 plus fps. Helpful in evaluating irregular or aperiodic vibrations. More detailed than stroboscopy but less commonly used due to cost. 6. Videochimography. High-speed imaging technique focusing on a single line of the vocal folds. Allows detection of asymmetries or irregular vibrations. Rarely used in clinical settings. 7. Laryngeal ultrasound. Non-invasive, but limited in visualizing deeper laryngeal structures. Primarily used in pediatrics or for surface-level soft tissue evaluation. 8. Laryngeal EMG, electromyography. It does not provide visual imaging but provides a functional electrical assessment of laryngeal muscles. Beneficial for neurological voice disorders, e.g., vocal fold paralysis. Audiological screening or evaluation. An audiological screening or evaluation is vital during a voice evaluation because hearing is essential for accurate voice production and self-monitoring. If a person has hearing loss, they may not hear their voice clearly, which can lead to abnormal pitch, volume, or resonance, increased vocal effort or strain, delayed or impaired voice development, especially in children. Identifying hearing issues ensures that voice therapy or intervention addresses the root causes and supports more effective treatment outcomes. A vocal profile analysis, VPA, is important because it provides a systematic, perceptual evaluation of voice quality based on specific vocal parameters. It allows clinicians to objectively describe and quantify the characteristics of a person's voice, such as pitch, high, low, monotone, loudness, soft, loud, variable, quality, breathy, rough, strained, hoarse, resonance, nasal, oral, balanced. Importance of VPA. 1. Diagnostic insight. It helps identify voice disorders by highlighting deviations from typical vocal characteristics. 2. Baseline measurement. Establishes a starting point for therapy and allows comparison over time. 3. Treatment planning. Guides targeted intervention by pinpointing specific vocal attributes that need improvement. 4. Outcome tracking. Assists in monitoring progress and effectiveness of voice therapy. 5. Interdisciplinary communication. Provides standardized descriptors that can be understood across medical and educational teams. In essence, the VPA is a valuable clinical tool that supports both the diagnosis and rehabilitation of voice disorders in a structured, reproducible way. Areas to assess for laryngeal function. Instruments needed to perform a comprehensive evaluation. 1. Piano keyboard or iPad app. 2. PF and FEV1 handheld instrument. 3. Handheld microphone spectrogram iPad app or computer-based. 4. Penlight OM supplies. 5. Stopwatch. 6. Models. Auditory discrimination of tones. Use piano keys. Random tones and semitones are presented at least 10 times, and the patient, with his back turned, indicates whether the two presented tones are the same or different. Acceptable parameters score 90 to 100%. Analysis of a voice spectrogram. Start with an oral mechanism examination to determine that all structures are properly functioning. The spectrogram allows a visual representation of the acoustic characteristics of a person's voice over time. It is used in voice evaluations to analyze frequency, pitch, intensity, loudness, temporal, timing, aspects of speech. Key features of a voice spectrogram. 1. Time axis shows how the voice signal changes over time. 2. Frequency displays the range of sound frequencies, measured in hertz. 3. Intensity, color or darkness, indicates the loudness of each frequency. Darker areas show stronger, more intense sounds. Importance of spectrogram analysis. Identifies vocal fold vibration patterns and abnormalities. Detects resonance and articulation issues. Measures formants, which are resonant frequencies important for vowel sounds. Assesses pitch stability, phonatory breaks, or vocal tremor. Provides objective, quantifiable data to supplement perceptual judgments. Clinical applications. Baseline voice assessments. Documentation of progress in therapy. Differentiation of voice disorders. Support for medical or surgical decisions. Analysis of a voice spectrogram includes minimum pitch, maximum pitch, pitch range, pitch average. Maximum phonation time, MPT, measures phonatory and respiratory efficiency, reflecting how well the lungs, vocal folds, and articulators work together to produce sustained voice. How it is measured. The individual inhales deeply and sustains a vowel sound without strain for as long as possible. The duration, in seconds, is recorded, typically across 3 trials, and the longest or average time is noted. Importance. Assesses laryngeal function. O reveals glottal efficiency, how well the vocal folds close and vibrate. O helps detect breathiness or air wastage in voice production. 2. Evaluates respiratory support. O indicates respiratory capacity and control needed for speech. O useful in cases of neuromuscular disorders, respiratory conditions, or voice fatigue. 3. Baseline and progress monitoring. O serves as a baseline measurement in voice therapy. O tracks treatment effectiveness over time. 4. Differentiates voice disorders. O short MPT may suggest conditions like vocal fold paralysis, muscle tension dysphonia, or reduced lung function. Typical values. Adults. O males, 25 to 35 seconds. O females, 15 to 25 seconds. Children, lower values due to smaller lung volumes. Optimal pitch refers to the habitual pitch range that best suits a person's vocal anatomy, e.g., vocal fold length, tension, and mass, and provides maximum vocal efficiency with minimal physical fatigue or damage. Observe and follow the formula for calculation. Maximum duration time, MDT, and the S and Z ratio are simple tools used in voice evaluations to check how well the vocal folds, or vocal cords, are working. MDT measures how long a person can hold a sound, like ah, on one breath. If the time is too short, it may mean there's a problem with breath support or the voice system. The MDT ratio is a component of voice evaluation that compares the maximum duration a person can sustain the voiceless sound S versus the voice sound Z. Normally, these durations should be nearly equal, resulting in a ratio close to 1.0, 0.95 and 1.05. A significantly higher ratio above 1.4 may indicate laryngeal pathology, particularly inefficient vocal fold vibration or incomplete glottal closure. If a person can sustain S much longer than Z, it may suggest issues such as vocal fold lesions, paralysis, or other voice disorders affecting phonation. The S and Z ratio serves as a useful screening tool for identifying potential laryngeal dysfunction and guiding further diagnostic investigation. Peak expiratory flow, PF. PEF is the maximum speed of exhalation during a forceful breath out after a full inhalation. It is measured in liters per minute. Relevance. Indicates respiratory strength and lung function. Important in voice assessment because reduced PEF can affect the ability to generate sufficient airflow for speech and phonation. Commonly used in pulmonary function tests and can signal airway obstruction or reduced respiratory support for the voice. Subglottic pressure is the air pressure below the vocal folds, in the trachea, that builds up during phonation before the vocal folds are forced open to produce sound. Relevance. Driving force for vocal fold vibration. Adequate subglottic pressure is essential for vocal intensity, loudness, and pitch control. Can be indirectly estimated using intraoral pressure during specific tasks. Low subglottic pressure can lead to a weak or breathy voice. High pressure may result in vocal strain or fatigue. 4. Airflow in voice production. Airflow refers to the rate of air movement from the lungs through the vocal folds and out of the mouth during speech or phonation, typically measured in milliliters per second, ml/s. Relevance. Crucial for efficient vocal fold vibration. Too much airflow may affect voice quality, causing a breathy voice, while too little may indicate strained phonation. Balance between subglottic pressure and airflow determines phonatory efficiency. Relationship between the three. Subglottic pressure and airflow work together to initiate and sustain phonation. PF provides insight into the maximum respiratory force, while subglottic pressure and airflow explain how well that force is used for voice production. Airflow is the amount of air that passes through the vocal folds during speech. Standard range. Males, 100 to 200 ml/SCC. Females, 80 to 180 ml/SCC. Peak FEV1, forced expiratory volume in 1 second, measures how much air a person can exhale forcefully in 1 second. Standard range, typically, 80% of predicted values based on age, gender, and height. Subglottic pressure is the air pressure below the vocal folds needed to start and maintain phonation. Standard range, 5 to 10 cm H2O for everyday speech. This is an important area since it is what distinguishes a competent SLP from a technician. The quality of the voice during the evaluation perceived determination is a skill. The perception of voice qualities relies heavily on the clinical judgment and expertise of the evaluating speech-language pathologist, SLP. Accurate discrimination requires a well-trained ear, developed through exposure to various audio samples representing typical and pathological voice characteristics. As part of the training process, participants must listen carefully, analyze, and identify specific voice qualities. Audio files are available on multiple websites to support voice analysis and skill development. Finally comes the SLP Voice Report and Plan of Care. The Voice Evaluation Report includes quantitative and qualitative results, comprehensively analyzing the individual's vocal function. This report serves as a structured collection of clinical data, which is carefully interpreted to identify the underlying causes or contributing factors of the voice disorder. The findings are then used to explain or hypothesize why the disorder occurs. If the results indicate that the voice disorder meets the criteria for medical necessity, the report will outline a recommended course of action, which may include initiating voice therapy. Treatment plans are developed to mitigate or potentially resolve the disorder. If needed, they may also incorporate technological assistance, such as voice amplification devices or augmentative communication tools, to support communication effectiveness and improve overall vocal health. This concludes the presentation. As a reminder, the speech-language pathologist is a well-trained clinician, not a technician. Therefore, theory and practice go hand in hand. Clinical judgment and SLP competencies go beyond simple tests. Use them wisely. Dr. J.G. Padin, CCC/SLP, MPH. KU Postdoctoral in Cultural and Diverse Linguistics. For more information, please contact padinagabriel@gmail.com.